Well, welcome everyone to our Experts Online, and we're going to talk about cochlear implants in infants. I'm Ilona Anderson, and I'm the Corporate Director of Clinical Research here at MED-EL HQ. Just to go through a couple of participant tips so that we're all aware of the etiquette of working online. Please name yourself, like your name, organization, and country, so that we know where you are. You can click that on your participants panel, and you can there rename yourself. To avoid background noise, please mute your microphone if you do not speak, and also mute your phone so we don't hear any ringing, so that it makes it comfortable for everyone to listen. Now, for a stable internet connection on your side, we recommend you close all programs, just keeping the Zoom open, and that gives you the best experience, I think. Your comments and questions are welcome. So either when it comes to question time, you can raise your hand and ask it, or during the whole session, you can write your questions in the chat and we will go through all of that. I just want to remind everyone that what you see here is not necessarily approved in all markets around the world. We do have English captioning available. You can click on the closed caption there to see exactly the captioning. Okay, so first up, we have our first Mentimeter. So either take a photo of the QR code with your phone, or enter the code there, 39236354, to get onto the Mentimeter so you can see our first question. All right. Has everyone got that, I hope? All right, so this is what our presenters would like to know is, what is your profession? Can you just write one word so that we can see what your profession is? Okay, we've got therapists, engineer, ENT, audiologists, speechies, some more. People who do language, audiologists and speech therapists, some engineers coming up, clinical engineer. Okay. Anyone else? It seems like we have, oh, supply chain. Okay, that's a different one. Teacher of the deaf. So that's where we go. Is anyone else saying? Well, I think we've pretty much got the range of people we have, with audiologists and engineers being the biggest group in attendance. Okay, thanks very much. Right, so we know we have newborn hearing screening in a lot of countries, and that means that we are identifying children with hearing loss from a very young age. But often they then go into early intervention and possibly get a hearing aid. But when do we provide a cochlear implant? This is really the key question we want to answer today. We see that with anatomy, the anatomy of the cochlea is fully developed at birth, and we have the final structure and functional maturation during that perinatal period. And I think this is one of the really good things for cochlear implant. Because early CI is not limited by any anatomical development. We also look at anesthesia and surgery because, of course, this is really important when we're looking at very, very young children. And one should always consider general anesthesia considerations. But a number of studies have said that there have been no extra anesthesia risks when we work with very young children. And certainly they are not really extra issues with surgical complications. And the list here says some of the things that have been in the research, but nothing over and above what we have in the normal situation. Sometimes the operative length might be longer in the under 12s, and maybe the length of stay in a clinic might be a bit longer in under 12s, months. I'm saying under 12s, not years, but months, just to make sure. Okay, what are the risks? There are no extra surgical risks or complications over and above a child implanted at an older age, and some studies have shown that there are few surgical complications independent of age risk. So it seems that there is no extra risk with implanting a very young child. Of course, there's the thing about how do we assess both before and after, and there are a number of measures that I'm aware of there. And also we need to especially consider fitting, because it is a different ball game than with an older child. So there might be ESRT, maybe ArtFit, and interesting to see what behavioral measures we get. So with that in mind, we can look at our outcomes, which shows that our research really is earlier is better. Early implants show faster language development, and that we see the mastery of basic auditory skills 6 months post-op in the infants. Also, that speech production is higher when an infant is implanted, and more children have oral-only communication. Right, so that brings us to our next Mentimeter. So if we can scan on the can we just keep that there? We scan on that QR code. Okay, so that we've got it. We've got an interesting question about when you implant your children. So if you can enter the code 39236354, and let's see where we go. All right, let's see the question. What is the youngest age you would implant a child? Please write the number and M for month and Y for year. Okay. So we've got 6 months is our youngest so far. 1 year old, I'm going to assume that. 8 months, 9 months to 1 year. Okay. 6 months again, 1 year. 10 months. Okay. 10 months, 6 months. Another 1 year. Where are we? 8 months, 9 months, 8 kilograms. Okay, that's an interesting one, because I think that does affect anesthesia. I think people are looking a lot at kilograms now. Anyone else? 10 months again, 8 months, 5 months. Okay, we've gone down from 6 months to 5 months. I was going to say was 6 months the limit, but we have a 5 months here. Anywhere else? Okay, I think we'll move on then, because I think that gives us a good idea that we are somewhere between 5 months to 1 year. And that might also depend on which region you are from, because I know that there are some regulations about that. Right. So I need to have my slide black. All right, so I'm going to introduce 2 speakers to you today who will go through their presentation together. The first person is Eva Karltorp, and she works at the Department of CLINTEC, Karolinska Institutet in Stockholm. Now, I've known Eva for a very, very long time, and I really admire her vigor and her enthusiasm in her surgical work. She is a world leader in providing cochlear implants to infants, and she's going to really provide us a lot of information today about why she thinks it is really, really important to get them earlier and better. In her spare time, Eva likes to work out in the garden, and she likes to run, she likes to go to the gym, and she also has time to look after her grandchildren. And she says she's scared to retire because maybe everyone might forget the very young children with meningitis. So although it's rare in her case, she said she still cares about them. So Eva, you're not allowed to retire at all. And then we have Ulrika Lovkist. She works at the Department of Public Health and Caring Sciences at Uppsala University, and also at CLINTEC in Karolinska. Okay, she also has many, many years of experience with early intervention. And I think, Ulrika, you're going to give us a wealth of information on maybe diagnosis and how you manage these very, very young children. In her spare time, Ulrika likes to walk in the mountains, and she loves her cats, and I'm a cat person, so we've got a good connection there. I'd like to welcome you both, and we're really looking forward to hearing all about your experiences. So if you can take over, that would be good. I both. Right, Ava and Ulrika.
Okay.
Please. Yeah,
I
good.
will unmute myself and share my presentation. Så, ska jag trycka här då. Yeah, so I and Ulrika, we want to share with you why we are so crazy about implantation in young kids. We want to talk about our clinical experience and a little bit of research in this field. So we want to tell you pros and cons with early CI intervention. Now, Ilona, you have told us everything about surgical risks, that there aren't any, but we will tell you a little bit more about that. And we also want to discuss, is it any difference in outcome in the long run when the kids are older teenagers or adults? So this is interesting, we think. But first, we want to share our CI story. Our story in Sweden and in Stockholm begins at 99 when we started with kids, operate kids. And the mean age at operation at that time was 3 to 4 years. And it was very sign orientated. So the idea was that the kids would start with sign language and then translate to oral language. But it didn't work very well. So the outcomes were quite poor at this time. I started at the team 99, and I soon found out that we had to do something. It was a desperate need of change. So what could I as a surgeon do, and what could we as a team do to change the situation? We could start early with infant operation because we had the screening in place in our hospital since 97. And thus we could also find the kids early, and we started with infants already 2002. We also could start a new audioverbal therapy setting, and Ulrika will tell you more about that later. So these three things, the screening, the early implantation, and the therapy for the coaching of the parents, made all difference in the world. So we say in Sweden that we switch the direction of the big boat. Do you say that in English, Ilona? So it was going one way, and we kind of switched the direction to another, completely other direction. I could hardly talk to any kids when I came to the CI teams because I was too poor at sign language, and now I can for sure talk with the kids. So that's a big difference. So I would talk about the first two issues, the screening and the early operation. And I suppose most of you have the screening, and we were, as I said, happy to have it early in Sweden and in our hospital as early as 97. And we find 2,500 newborns with hearing loss, with permanent hearing loss. And that means around 50 kids in the Stockholm area per year. So we could fit them early with cochlear implants and hearing aids if they need. Almost all those kids have hearing parents. That's interesting. So they want to communicate with the kids by spoken language. So the big benefit of the screening is that we not only could find the kids, but we could reach the parents early. We could get hold of the parents really early. And as I said, fit hearing aids and CI early. And the parents they were willing to do the job for sure, if we met them early and could talk to them early. So if you have the screening going, fight for it. And if it doesn't work well, fight to get it started, because this is the best thing that has happened ever in my field. Without the screening, we would be out of we could never operate those young kids. So the screening, fight for it for sure. The big part I would talk about are the early operations. As I said, we started with infants 91, no, with kids 91 and infants 2002. We had started to lower the operation aids already before 2002, but that year we were ready to go for the infants. And they are now young adults. Can you believe 2002? It's almost 20 years ago. And 10 years later, we started to operate kids even younger than 6 months. The operation is, the parents are sometimes afraid of the operation, but I say that it's a tiny operation. It's a tiny incision behind the ear. And you can just barely put in the implant under the skin, and the ears are quite small, but you make an incision big enough for the implant house and press it in like this. And afterwards, you can't see anything, because the incision is where the ear is sticking onto the head. So this is directly after the operation on one of the babies. And after the operation, the mom can come in, and the hard part is over, because all parents, they don't like to leave their kids to the operation team, of course, but they are doing an excellent job. And this is a couple of weeks after the operation, and you can see perhaps see the implant under the skin. But when the hair grows, you can't even see the implant. So these are the numbers from us in Stockholm. These are all kids under 2.5 years of age and their operation age. So you can see that it varies. So not all kids are operated at 5 months. Only 27, I can see, or 28 up to this day, and many 5 or 6 months. But the highest bar are the 8 months old, and then up to 29 months. So it depends on many factors, what age you can operate, of course. But we want to lower this, not perhaps below 4 months of age, but we want to get the whole group earlier. So most kids benefit from to get their operation done earlier. This is another view. So when we started early, they were much older, 12 to 29 months of age. And then the kids came in here, the babies here at 2002, and the 6 months olds here, 2012. You can see that there aren't that many under 6 months, but it's a little group now. Why aren't all babies operated so early then? Well, you have to be really sure of the diagnosis, of course. You have to be 100% sure, and sometimes you aren't sure, and then you can't operate that early. The kids have to be healthy, and we don't go on for the premature kids at those really early months. So we let them grow a little bit more. And it's only the severe to profound that we go for super early CI operation. The later kids might be progressive. Many of these 8, 9 months old, they had better hearing from the beginning, and then the progression of the hearing loss made them be candidates for CI when they were 8 or 9 months instead. But the big group are also the skeptical parents. I don't know if you have them in other countries, but here in Sweden, we have a big group of parents that don't trust the medical people. I spend a lot of hours talking to these parents and trying to get them understand that their kids need a cochlear implant. Just this last week, I have a couple of those parents. They give me gray hair. I work hard to try to make them understand. And sometimes the kids are 2 or 3 years until the parents accept, okay, they need a cochlear implant. They don't talk as the others. And then they have lost 2 or 3 years. But most of the kids most of the parents I can talk into the cochlear implant quite early. And it's also quite a big group of kids that I call are in the gray zone. We don't know if it's enough with the hearing aid or not. We don't know if the hearing aid will give them acquisition to the spoken language or not. And in most cases, we have to wait for a while and to see how they are doing with their hearing aids first. The complication, Ilona already told us, it's very low for all kids, very, very few complications. And it's not a high risk among those babies. Of course, you have to have a pediatric anesthesiolog team. That's mandatory. You have to have pediatric anesthesiologs that knows how to sedate the kids, of course. But if you have, it's no problem really. So why are we so keen about this? We want to show you the results. We put together a study with 103 kids that operated from 2002 to 2013. And it's only the kids with typical development and only kids from monolingual homes, because we wanted to see what the age of operation did. So we had to clean the material kind of. So it was 103 kids when we had picked out those kids that were good for this study. And we did Raynell test, language understanding test, and we did speech intelligibility test. Or we did a lot more. And if you want to see more about it, please read this article. I think it's quite good. And you get more information if you read it. But I want to show you some of the results right now. These are the tests with Raynell, this language understanding, and every little line is a kid. So these are kids that were 24 to 29 months at operation. And the dotted line here in the middle, this is what it should be. So if you are 3 years, you should be as a 3-year-old. If you are 5 years, you should be as a 5-year-old here on the dotted line. So you can see they are a little bit lower, they are a little bit behind. If we operate them younger, 18 to 23 months, they are getting closer to the normal hearing kids. 12 to 17 months, you see that it looks much better. And 9 to 11 months, they are almost in the same area as the normal hearing kids. And those even younger kids are doing even better. You see it better if I put it on put them all together like this. So the older kids, even the 12 months old, they struggle to get in touch with the group of normal hearing kids. But if they are under 1 year of age, they do get in touch with the kids with normal hearing at around 4 years of age. And if you operate them even younger, they aren't even delayed. And that's what parents tell us. We don't see any difference between our deaf kids with cochlear implant operated at 5 months and their normal hearing cousins at 1 year of age, if they have the same age, or the friends' babies or so on. So they don't even notice a delay. This is another way to check when this is one testing point. So this kid has been tested, this is the same kid, has been tested 4 times with Raynell test. And then we draw a line between those tests, and then you can do an estimation at 4 years of age, what language age will it have? It will be above 4, just this kid will be above 4. So it will be even earlier than a normal hearing 4-year-old. So if you put all those kids on one slide, so every little dot is a child with a lot of testing behind every dot. Do you get it? So it's a lot behind every dot. And this is what you should be at 4 years of age. You should be as a 4-year-old at the norm tests. So these are the early operated, before 1 year of age, 1 to 1.5, 1.5 to 2, and 2 to 2.5. And the higher up the the better their language understanding is. So you can see kids operated before age of 1, they are even almost at 6 years or 5.5 years, or many around 5. I could never, ever believe this when I started in the 90s, that the kid could do so well. But you see, it's a big spread of the kids. We have so no, did you miss something?
Yeah, I think we got to having something you couldn't believe in the 1990s.
Okay, so I could never believe that the kids could do so well in the 90s, that they could even be earlier in the language development than the normal hearing kids. But we have, you see, it's a big spread of the kids spread out. See if I can, now I can't. Martin, why can't I change the slide? Okay. It's very slow. Okay, now. So this is, all those red kids are kids with foreign language. Parents have foreign language or sign language in the family. So you can see that they are a bit much lower than expected. These are kids with severe malformations, and as expected, they are lower in their language outcome. But as a group, can you see how normal they are compared to the 2-year-olds? And 2-year-olds, that was early in the 90s. So this is amazing. And even more, we see how this kids sound, the speech intelligibility. The earliest operated kids, they are doing the same as the normal hearing kids. And the older they are, when they are operated, the longer time will it take till they are understood from others. And that's very important, to be understood from others. So now we will do a new prospective study, follow-up study. This was a retrospective study when we checked our data backwards, kind of. So now we'll put up a prospective follow-up study. What are the long-term effects? And we will do it really, really thoroughly. Check their language outcome, their listening abilities. Also, we will test their balance, check etiology and quality of life and mental health. So we will call in all our teenagers and test them, and we hope we will have 100 kids in this study, and age-matched controls for the language test, and we will start now in January. We should have started 1 year ago, but the pandemic came in our way. So this is exciting for us. Will this results that I showed you just recently, will they even last until teenage and or even up in adult age? We don't know, but we think so. Ulrika, I hand over to you.
Okay, thank you very much. Well, this is exciting times, and I will talk about the intervention and what can we do besides implantation. But I just want to remind you a bit about what are the children missing if we're not implanting them early enough. So there are 2 aspects to remember. One is the auditory deprivation, and another is the brain plasticity. So we know that infants' brains are very plastic, like Ilona was telling you in the beginning. And this means that if we reach the brain early enough, then we might see these results that Eva showed you, that they are more like normal hearing kids in their performance in tests. But the auditory deprivation, Eva, can you change picture? That means the time until you can have good enough hearing. So for deaf children, that would be cochlear implants, but that's also relevant for children who need hearing aids, of course. And we know from studies that the brain might reorganize if we don't reach the brain with auditory stimulation. And some of the effects, there are primary effects and there are secondary effects of this process. So if children have a longer period with auditory deprivation, they will miss out on the listening experience before birth, but also in the pre-linguistic period, before they have hearing technology, they will miss out on communicative experiences, listening, and use of their own voice. And this will influence on babbling and also on the early audio-verbal communication skills. And this will later then have a negative effect on phonology, vocabulary, grammar, and pragmatics. And there's also exciting studies showing that also cognitive processing skills, not always related to hearing, will be affected if we don't reach the brain with auditory stimulation. So that could have negative effects on phonological awareness, executive functioning, and reading skills. Next, please. So these are the negative effects. So then we can also talk about the positive effects for the environment if we reach the child's infant's brain early. The child will have early access to audition and spoken language, and this will promote preventive actions. When I started 2001 as an SLP in Stockholm, I worked with children who were 2-3 years old. Then we had to go back and train skills backwards. Now we can expect more synchronized listening and language development in relation to the child's age. So this is very crucial. And this also makes parents changing their behavior because they can use more age-appropriate and more natural stimulation in their strategies, like the parentees, which is commonly something we don't think about, but we use with young children and infants. So this is very important. Next, please. I'm sure that many of you are aware of the recommended policy for 136, meaning that you should screen all infants before 1 month of age, that you should have a hearing diagnosis before 3 months, and that you should fit hearing technology and provide family-centered early intervention before 6 months. Recent studies show that if we can reach the 1, 2, 3 policy, then children will have more normal language development, especially in vocabulary. So this is very exciting. So now we should aim for 1, 2, 3 if 1, 3, 6 is in place in your country. If you don't have screening, of course, you have a longer way to go, but it's important to remember this policy because it has meaning for the development. Next, please. So what we have achieved in Sweden, we have achieved screening, we have achieved early implantation, we also have family-centered intervention, but still we don't reach all children or families. And we have very little research in looking into what kind of aspects are especially important for strategies, considering the parental linguistic stimulation. But here we have a meta-analysis from Austria, Holzinger et al. They have looked into the impact of family environment on language development. And they found that this is a factor that can explain 30% of the variance in language outcome. So this tells us this is really important to pay attention to. Next, please. Another exciting study is from the US by Quittner et al. Many of you might have already read this, but they show that maternal sensitivity and cognitive linguistic stimulation in early years have, is a very important and was similar important at the age of cochlear implantation. So what does this tell us? Yes, there is something here that we can change. We cannot change always on the children's prerequisites when it comes to genes, when it comes to parents coming for the visits and going for early cochlear implantation, but we can control more for how do we support parents, and we should really both give them early access to hearing and early access to parent educations. So let's take next. And a brand new study also from the US, they show that self-efficacy, that means how comfort I feel as a parent in how to handle the situation with my child with hearing loss, is a really important factor for the outcome of the child. So again, it's the same kind of story as the last study I showed you, but parents have really a key role in facilitating the child's CI success. So these authors, they suggest that all CI teams should have parent educations ready when you have children coming in to the clinic. Next. So, okay, so this is important to have parent education programs. And we know that maternal sensitivity or caregiver sensitivity are important factors. Another factor that is also shown very interesting results is that verbal turn takings, the amount of verbal turn takings, is also a factor that might affect the brains of a child more than socioeconomical factors, which is all very exciting, because this means you don't have to have a PhD to be a parent who can stimulate your child's learning ability. But some parents need more education and more support to know how to make turns and how to communicate with the child. So this is very important. Next. So then you know a little bit about the background about which factors are important for the child to learn language. And we know that support system is important, not only implantation. So in Sweden, we implemented AVT 2003. It was a small scale initially. Today, I think there are around 100 therapists who have undergone education, 1-year program. And we have a few therapists who are certified in this method. So this is implemented. We can reach families. However, we still struggle to reach some of the families. Families from lower socioeconomic status level or with multilingual background is one group, but it's also parents who think that, well, now we have technology, then it's enough. So it doesn't always have to be with socioeconomic status. But AVT is a method that is based on 2 aspects. It's close partnership with parents who learn how to stimulate spoken language. And listening is the foundation for the spoken language development. So that's the 2 aspects. So you could also see it's like a diagnostics intervention option. But we have not reached all families yet. So this is a bit problematic, I would say. Next, please. And then you can check, yes. So I mentioned that the children or families with multilingual background is one group that we're not reaching 100%. And this is actually a quite big group. 30% of our cohort, maybe more now after 2015, has a multilingual background. Next, please. What we know is the majority come from countries where Arabic and Somali is the main languages. Next. And the majority of this cohort of 30% have 2 parents with another mother tongue. Next, please. The same numbers we can also see in Norway, 30% of the cohort. Next. And what they found in, you can take the next one too. What they found in a study by Amundsen, next please, was that it was a higher incidence of CI in children with a non-Nordic versus Nordic ethnicity, which reflect or indicate a higher incidence of profound deafness. And despite that these children were born and receiving care in Norway, prelingually deaf children with non-Nordic parents were at risk at receiving CI later than Nordic children. So this is something I think we need to work more with, and maybe we can discuss after the presentation, this aspect. Next. Another factor that we have found in another project, which is called Words Make a Difference, we use the LINA technology to measure the home environment regarding language, communication, and listening. What we found in that study was that there are, even if they're very equal between male and female caregivers in Sweden, we found some interesting results that 70% of all words that are said to young children in Swedish homes comes from female caregivers. And it's, if you look at the graph here, you can see that the children with CI and hearing aids, the difference is more profound. Yes. So this tells us that mothers takes maybe more responsibility for the language in these families, which is known from the literature in other groups of children with disability. Next, please. So what we have done now is that we think that all parents with a child with moderate to severe hearing loss need some kind of starting intervention program, maybe before they go into AVT or something else. So a 12 weeks program where parents are the target group to educate parents. Why is it important to use the hearing aids or hearing technology full time? How can I do to be more sensitive to my child's own signals in communication or emotions? And how can I promote more verbal turn takings? So it's a preventive education program for parents. Next, please. So there are 5 goals, and these 5 goals are measured with objective tools. So we use the LINA technology to measure if the parents increase their numbers of verbal turn takings. We also use video analysis with protocols and check for parentees, and we check for sensitivity to the child's needs and communication. And the parents are also encouraged to use a new method with the mind map technique, where they are inspired to take these goals and write down, what do I know now? And next week, what should I learn more about? So this document will then tell us after these 12 weeks, what should this family focus on later? Next. So far we have just developed the program. We have had 10 families in a pilot. What we can see from the results are that parents quickly become aware of their own use of parentees and also language. We don't see any problem with using the hearing technology. In this cohort, we didn't see problems with sensitivity. And interestingly, we could see that the family who were waiting for CI investigation continued to talk while the child was waiting for CI. And in some 2 cases, we could see that the speech changes and became lower incidence of utterances. And then we could see that the hearing was dropping. So maybe we can also use Lina to measure these kind of developmental differences. And we also learned from these 10 families that even if we have like a protocol for what to do every time, we need to adapt to the family's unique nature also. Next. And lastly, I want to share some of the advices from these 10 parents who have gone through the PEP. We had a focus group interview with them, and we asked what advice would they give to other families with a recently diagnosed child. So we have parents here who says, talk, talk, talk. Or I think that all families should get PEP. Talk a lot, but do not feel stressed. One day you will see that it works. Feel calm and do not worry. It will go well. They, the children, will learn and develop, even if it's not perfect all the time. So this gives me information as a researcher and for us clinicians that we also have to be aware the parental knowledge can also be used to improve our program. So this is really interesting and important. Next. So the take-home messages, because time is flying and we need to have some time for questions, is that the 1, 2, 3 policy is crucial. That's really a rule to be able to implant at 4.5 months. You need to be sure about the diagnosis. So early is important. We should also include parents more in this phase and focus on parental involvement from the start. And also use more data-driven intervention, like to use the Lina technology is one example. This may lead to better outcome because the parents are motivated when they see the graphs and they get more aware quickly to change their behavior. And lastly, surgery on healthy infants is safe. And then next, please, and Eva, you can come in here too.
Yeah. Yes, and Ulrika and I just want to thank you for listening to us, and we want to acknowledge our fantastic team in Stockholm. Here are some of the members of the team, and of course also all the wonderful children and parents that we meet.
Yes, and I would just want to say, I want to acknowledge the clinicians and researchers from all over Sweden that are working in the Words Make a Difference project, who's developed the PEP intervention.
Of course, it's very important.
Thank you. Ready for questions?
Yes.
Wow, thank you both. I think it's outstanding what you do, really. I'm very, very impressed, and I think we've got a few questions on the go. What are you using to determine diagnosis? Not only from an objective measure, but maybe from a language or pre-verbal language. What are you using? I think lots of people want to know this.
The diagnosis. Eva, you should go first.
But I think it was the language part of the diagnosis. The question
sorry. Yes, with these young children, we use parent questionnaires, and we use the Lina technology. We have developed like observation protocols to check on interaction. It's not easy to use like standardized Rainel. It's not possible with a 3-month-old. And we also are validating the little ears expressive questionnaire in Swedish and in Norwegian. I think that will be very useful for our practice. And we also have little ears.
Yeah, I think the success of Little Ears has really helped. And I think now with the pre-verbal of the speech production questionnaire, I think will give us some great information there besides the technology. And how would you be looking at it from a surgical perspective, Eva?
How do you look?
Or what else would you use? We've done the parent questionnaires, the objective measures.
Yeah, we have the objective measurement, and of course we test the kids over and over again with the hearing aids on. So both electrophysiological test and the real test in real life. Mm-hmm. But we also have developed directional hearing for babies. So we have started to use this as it's very easy to get the kids' attention. So we have also started to use this as a tool.
Yeah. And so when you work with parents, you said you've had to convince some parents. So do they meet other parents, or how do you manage that process?
I think it's the same all over Sweden, that it depends on where you live, that you have your habilitation team close to you, the city you live in. And then you are sent to us, for example, or another cochlear implant team, and we just add on to the basic things that are done in the home city. But they often meet other families. We used to do it all the time, also in the CI center before the pandemic. That was the best thing. They loved to meet another family. Mm-hmm. And now we will start again, of course. But for a year now, we have had to skip this part. But otherwise, I always ask at the end, or they come to us for a full day, and I always ask the families at the end of the day, what was the best today, to meet another family.
Yeah, I think it kind of makes it a bit more real.
Yeah,
really. And do you use well, what we haven't seen is how many other children in the family might have a hearing loss. You know, sometimes there are siblings that come along. So once you've got one child in, do you speak to the parents about using some kind of genetic assessment to see what might come in the future, or to define etiology, something like that?
Yes, we always try to define etiology. Nowadays, we test all the kids genetically. We don't find the gene always, not even today, though, unfortunately, but we always try to find the etiology. And the perfect child is the child that we are 100% sure about the hearing loss, and we have the genes. We know that it is, for example, connexin 26, and we know that it's a gene that gives a severe hearing loss. Then we are very sure.
Yeah. Okay, I could have a million questions, but let's go and see what's in the chat. So the first one was someone, if we can just go up. I don't see who that is, doctor. Sorry, I just can't see it in the chat. But anyway, they said, do you implant only one side for these young children? Or if you only use one CI, when do you plan to implant the other? So essentially, are you doing simultaneous or sequentially? And
we started 2004 with bilateral implants. I forgot to tell you that almost all our kids have bilateral implants. Around more than 90% of the young kids have bilateral implants. But we did start, but we did start with bilateral implants 2004. And then after some years, then it was the second implant operated in, but then we started with simultaneous CIs. And then for a short while, we were pausing this because we didn't know about the vestibular risk. But now since 5-6 years, we do simultaneous again. The only time when we don't do simultaneous are the malformed kids. Sometimes it's it's too difficult, the operation, and we need to know if something is not working well after the operation. We need to know which side was not working. So that's the severe malformations. We do one at a time.
Yeah, good. Okay, Yvonne Siebens wanted to get the slides. Yvonne, we do record this session and they are loaded up onto the MED-EL Academy, so you can watch things again there. Okay, so Rita said, many thanks for the great presentations. And you're saying that some of these children implanted, say, at 5 months of age, show even better language development than a normal hearing child at the same age. Ulrika, what do you think are the factors playing a role here? Because it is interesting.
It is interesting, yes, it is. I think the family engagement and involvement is one important factor. And because this is a family who get intervention, so if they are intervention, they might do more of reading, more of stimulation. So that could be like boosting language. We think that is really nice and really important to do, because they will have more difficulties to hear in some certain environments. So we need to boost the children's brain. And also, if we do this early, the child will start to ask questions and also be interactive. So it's not like only providing language. It's like, like I say, the dyadic. The children are already born to be developing, what to say in English, their prerequisite is to learn language. But also I think IQ is one factor, so non-verbal cognitive abilities also, and I would say also that we also see differences according to etiology. So some that are implanted early might not develop that well because they have other additional needs.
Yeah.
But those are also in favor of early intervention and early cochlear implantation, because then we can find these other more difficulties for this child and make sure that intervention is provided for those families.
Yeah, Eva, you wanted to say something?
I think the child could be, how should I say in English? It could be itself. So if I think the kids that are early now, the deaf kids that are operated early and that are early in the language development, they should have been early if they weren't deaf.
Yeah.
If you see what I mean. And you know, the first kid we operated as an infant, he's now 21, 22, and he's studying law in Stockholm, and he's number 1 in his class. Can you believe it?
Yeah, I think the thing is, you know, what goes on in the brain.
So amazing.
For hearing impaired and people with normal hearing.
Yeah.
You know, and even in the test with normal hearing, some of them go above that kind of age anyway. Yeah. Okay. So Timo has asked, can you mention some examples where an adaptation of the PEP is necessary?
Yes. So it could be that some parents have more difficulties to use parentees. Then we have to pay more attention to that skill. So it's more like maybe we don't achieve all 5 goals during 12 weeks, but because they're using this mind mapping evaluation, we know where to go next. And we always have like the foundation is that they should use the technology full time. So far, we don't have that problem because we come to the parents so early. But that could also be something that we have to adapt to check that they use hearing technology. Might be the first goal.
Yeah. Eva, a question. These youngies, a lot of them are in their teens now and stuff. Are they rejecting their CIs? Or are they happy to kind of be in a hearing and non-hearing world?
All the 103 kids I was referring to in our study were going to normal schools.
Yeah, yeah.
So they have to have hearing aids. They all use full time.
Yeah.
They can't be without it.
Yeah.
Okay, I'm going to say there is so much in this, and we haven't even got to what would be like fitting or everything like that. So, you know, for me, I think working and looking at implanting children or infants, really, I think that's a whole workshop in itself. So we must put that in our hat to think about. And I want to thank both of you, really. It's been a wonderful, wonderful presentation. And I so admire the work you do. I was many years ago trying to be part of a government scheme to get newborn hearing screening up in South Africa, which is always an interesting thing, never mind in really the first world countries. But I think everyone should try and do the best they can to help these children, and really young children, really fulfill their potential. And I think that's really our ultimate goal, is for each individual to fulfill their potential. So I want to say thank you both very, very much. I think there's a lot of information here that people can take forward. And
thank you.
I wish you both good holidays.
Okay.
Yeah, to you too. And to everyone, thank you for listening.
Thank you.
Thank you.
All right. So everyone else, thank you very, very much for joining us. This is our last Experts Online this year. I do wish you a nice restful time over the holiday period for those who have us. And if not, sorry you have to work so hard, or yeah, you're going to have to work so hard. But we're back again in January, on the 12th of January, and we're going to be looking at the best practice for SSD. Is it adhere or bone bridge or CI? How do you define that? We look forward to hearing from Professor Paul van der Heynen and Professor Piotr-Henryk Skarczynski. Same time, 3 o'clock, same place. See you then, and have a good day.